Hello everyone. Welcome to this session of the Global Classroom. Today we will be discussing another topic in surgery which is very important. This is carcinoma of the pancreas. I've had a long journey in medical education spanning a couple of continents. India, where I grew up and where I practiced surgery initially, and where I was a professor of surgery, and more recently in the US, where I have been working since 2003 as a professor of surgery and doing transplant. The objectives of this class would be to discuss early diagnosis. Remember, I'm fixated on diagnosis with clinical and pathology correlation, or CPC. The next will be to discuss the different ways in which people approach this disease, which has had a dismal prognosis for the last 50 years. Michael Trede had a famous statement in the 80s when he was writing about carcinoma of the pancreas, in which he divided people into realists, optimists, and nihilists. And I'm hoping that by the end of this talk, you will be more in the category of realist, or maybe even shifting or trending towards optimism. Lastly, we will discuss screening in carcinoma of the pancreas, and I'm afraid surgery will have to be a topic for another lecture because this is going to make this lecture very long. A few statistics to start off. Worldwide, carcinoma of the pancreas is having its highest incidence in the two countries, Hungary and Uruguay. In the US, there's a slight male preponderance, but around 62,000 new cases are projected to be diagnosed in 2024. A high-volume center treating carcinoma of the pancreas will usually operate between 100 and 200 patients a year. So you can do the math. It will take at least 150 to 300 high-volume centers specializing in cancer pancreas to be able to accommodate this much of a load expected in the next year. Worldwide, over 500,000 cases were diagnosed in 2020. The main risk factors are again universal: obesity, especially central obesity or abdominal obesity, type 2 diabetes, and smoking. The mean age at diagnosis is 71 years. Overall, carcinoma of the pancreas is the 11th or 10th most common cancer. However, it is the third leading cause of death. That just shows you that this is a pretty fatal diagnosis when you do make the diagnosis. There is an impression worldwide that carcinoma of the pancreas is increasing in incidence. In Australia, they have actually agreed that environmental toxins are a cause of carcinoma of the pancreas. This has huge significance. Most other countries don't have this, and smoking is supposed to be the number one toxic exposure that predisposes to carcinoma of the pancreas. In the US, very often we hear veterans who have served in Vietnam trying to blame toxic exposure to Agent Orange as being responsible for their carcinoma of the pancreas. There are also other toxic exposures which soldiers have suffered in more recent wars, where they have been exposed to a lot of smoke from incinerating things. Pathology. As we know, the pancreas has got an exocrine part and an endocrine part. So carcinomas will also be of exocrine or endocrine origin. Exocrine carcinoma of the pancreas is the most common one. And of this, pancreatic ductal adenocarcinoma, or PDAC, is the commonest pathology. Acinar carcinoma, which arises from the acini in the pancreas, is much less common and has a slightly better prognosis than ductal cancers. Probably the best prognosis of pancreatic cancers is in the neuroendocrine variety, which are also called PNETs, P-N-E-T. The location of the carcinoma in the pancreas is most commonly in the head of the pancreas. 60% of carcinomas are in the head of the pancreas. And that actually may be a good thing, because Carcinomas of the body and tail are notoriously late in presentation and late to be diagnosed, whereas carcinomas in the head of the pancreas can be diagnosed early because they usually present early. Within carcinomas of the head of the pancreas, there is a small subgroup called the periampullary carcinomas, and these are perhaps the best prognosis because they will arise in the area of the lower end of the bile duct, and they present with bile duct obstruction. And if this can be picked up early, these carcinomas can be diagnosed and resected at a time when there is still a potential for curative resection. So being able to pick up periampullary carcinomas is extremely important. When you look at the prognosis of these carcinomas in the periampullary region, there are 4 of them. The lower end of the bile duct, if that is the source of the primary, then it is an extrahepatic bile duct cancer. These carcinomas are notorious for a severe desmoplastic reaction which encases the bile duct, causes jaundice early, and does not spread very quickly. So picking up a lower end bile duct tumor is usually one with a good prognosis. You also have a periampullary lesion. The ampulla projects into the duodenal lumen and it can slough off and cause GI bleeding, anemia, and jaundice. Sometimes this jaundice may be fluctuating jaundice and difficult to differentiate from bile duct stones. However, this is another diagnosis that can be picked up early. Duodenal carcinomas can be of poor prognosis because they arise in the duodenal mucosa and they can be quite extensive or even circumferential, but they will also present with early signs of either bleeding or obstruction or jaundice and are amenable to early diagnosis. These tumors, which are in the head of the pancreas, are either pancreatic ductal adenocarcinomas or pancreatic neuroendocrine tumors, and of the two, both of these can be detected early and resected with curative intent. So periampullary tumors, 4 different cells of origin or tissues of origin, early diagnosis is possible. And this is an opportunity for us to help the patient by quick and early diagnosis. Back to basics, anatomy. Perhaps the best way to illustrate the anatomy is to hand draw it, and I will proceed to do so, showing you the head, neck, body, and tail of the pancreas, and most importantly, the relationship of the bile duct and how this can, if it's obstructed, if it's diagnosed early, can provide the best opportunity for resection with curative intent in carcinoma of the pancreas. Back to basics, anatomy of the pancreas. There is a head, body, and tail. This is one of the few organs that extends across the midline. Head, body, tail. Separating the head and the body is the neck. The neck is where the portal vein forms at the back of the pancreas and goes up to the liver. It is formed by the splenic vein and the superior mesenteric vein. Coming on top of the pancreas from the left, going to the right, from the aorta, is the celiac artery. It gives off the pancreatic or the splenic artery, continues as the common hepatic artery, and goes up to the liver. The splenic artery runs on top of the pancreas and then supplies the spleen. The superior mesenteric artery comes off the back of the pancreas and runs along the left side of the superior mesenteric vein. These are the arteries that are closely related to the head of the pancreas and the veins. Celiac artery, splenic artery, common hepatic artery, superior mesenteric artery. The veins, the superior mesenteric vein comes up from the intestine, joins the splenic vein coming from the spleen, forms a portal vein behind the pancreas, and comes up and goes on to supply the liver. Here is a CT scan of the pancreas, and the important vascular structures around the head of the pancreas have been marked, labeled, and it is important that you repeatedly look at CT scans of the pancreas whenever you have the opportunity, starting with the most posterior structure, which is the aorta and the IVC, and as you progress anteriorly, you will identify the different arteries that encircle or provide a rich anastomosis around the head of the pancreas between the arteries of the foregut and the midgut. These are marked in the CT scan. There are 3 symptoms of carcinoma of the pancreas: weight loss, pain abdomen, and jaundice. These are the classic 3 symptoms which you have to look out for. Weight loss. In the beginning, this weight loss may be actually welcomed by the patient because to start off, they are usually obese, usually have midline or central obesity, and when they lose weight, they don't really think this is a problem. Or they may be actively trying to lose weight, and when they start losing weight, they feel very happy. Late onset diabetes is something that you have to be very careful about because the weight loss can be attributed to a new diagnosis of type 2 diabetes. Well, most people get type 2 diabetes diagnosed in their 40s and 50s. So type 2 diabetes diagnosis with weight loss in a 60-year-old or somebody over 60 is something to have a very high index of suspicion. The pain abdomen is usually typical pancreatic pain in the midline, high up in the epigastrium, radiating to the back. Many tumors in the abdomen or anywhere else in the body tend to present with pain as a late symptom. However, in foregut tumors, pain is very often an early symptom, and that has to be remembered. So when somebody in his 60s or over presents with abdominal pain, you have to have a high index of suspicion that this is not a benign condition, this is a malignancy. Jaundice. Remember, jaundice in a malignant situation or malignant bile duct obstruction is classically described as painless progressive jaundice. In fact, very often this starts with pruritus. Pruritus is a very prominent part of the presentation of malignant obstructive jaundice, and sometimes the diagnosis will be picked up by the alert dermatologist. There is one situation in which the jaundice may not be progressive but may fluctuate, and that is in the periampullary carcinoma, which we talked about earlier. When the carcinoma sloughs, the obstruction goes away and the bile flows, and jaundice may be relieved temporarily. You have to be able to pick up the fact that these patients, around the time that the jaundice goes down, also have features of upper GI bleeding with dark, tarry colored stools. The combination of clay colored stools, which occurs in obstructive jaundice, with occasional GI bleeding, altered blood, which is black in color, that combination has to be picked up, and it is an important clinical feature. Moving on from symptoms to clinical findings on examination. The most important finding is summarized as Courvoisier's law, where a palpable gallbladder in association with jaundice is usually a sign of malignancy of the lower end of the bile duct. In tumors of the body and the tail of the pancreas, there may be no clinical findings whatsoever. In today's day and age, we have to remember that ultrasound is literally something that can be performed at the bedside. And doing a bedside ultrasound to look for dilatation of the bile ducts within the liver is very easy to do. And when that is done, if you see that the gallbladder is also dilated, then you can be pretty confident that the obstruction is malignant and at the lower end of the bile duct. Ultrasound is of limited value in tumors of the body and tail because the colon overlies the pancreas, and if it has got gas in it, it will reflect the sound waves and not show you any detail at all about the pancreas itself. I will now proceed with a hand drawing to illustrate to you the basis of Courvoisier's law, which says that in the presence of jaundice with a palpable gallbladder, think about a tumor at the lower end of the common bile duct and not gallstone disease. From the liver, a right hepatic duct and a left hepatic duct come out and travel down towards the head of the pancreas. On the way, the cystic duct joins coming from the gallbladder. The bile duct goes on and runs into the duodenum through the head of the pancreas. If the obstruction happens in this area, it'll cause back pressure in the whole system. This will lead to dilated intrahepatic bile ducts and dilated gallbladder. In the event that the lower end of the bile duct is obstructed by stones, what is important to remember is that your bile ducts come like this, cystic duct here, and as it goes down, if stones are obstructing the bile duct, these stones have usually come from the gallbladder. Chronic cholecystitis results in scarring and shrunken gallbladder. A scarred and shrunken gallbladder with stones may be associated with obstructive jaundice due to stones in the common bile duct. If the gallbladder is dilated, even if it has some sludge or stones, you have to think of the diagnosis of malignant obstruction at the lower end of the common bile duct, not stone disease. The differential diagnosis is two, both of which are benign conditions. Choledocholithiasis, causing jaundice and abdominal pain, and chronic pancreatitis. Remember, both of these conditions can be associated with carcinoma of the head of the pancreas. And removing gallstones, which are impacted in the lower end of the common bile duct by ERCP, which is easy to do for most gastroenterologists, may not be the end of the problem. There may be an associated carcinoma of the head of the pancreas which had gallstones in addition. Remember, only a high index of suspicion can result in an early diagnosis of carcinoma of the head of the pancreas. As doctors, we are prone to wishful thinking just like everybody else. When you go into a patient's room, you are not trying to find something evil that is going on there. You are all the time looking for something that you can give the patient a sense of hope. But that's not our job. Our job is to make an accurate diagnosis. Sherlock Holmes was not being wishful when he looked for evil and making a diagnosis of something bad. Once you know what is going on, then you can impart hope. But to go in without a high index of suspicion that you're going to find something bad will lull you into a sense of complacency in patients where a differential diagnosis is being entertained of stone disease or chronic pancreatitis. The differential diagnosis can also include malignancies of the common bile duct. One of these is called the Klatskin tumor. This occurs at the confluence of the right and left hepatic ducts at the hilum of the liver. The next location for a malignancy in the bile duct is in the middle of the bile duct, usually where the cystic duct joins the hepatic duct, and tumors of the common hepatic duct can occur and have to be differentiated from Miritzi's syndrome. Tumor obstruction of the right hepatic duct, left hepatic duct confluence is called a Klatskin tumor. Obstructions can happen towards the middle of the common bile duct or the extrahepatic bile duct at a spot where the cystic duct joins the common hepatic duct. Tumors in this area, common hepatic duct tumors, can mimic stone disease. If a stone impacted in the gallbladder causes obstruction or scarring in this area, it is called Miritzi syndrome. Obstruction below the confluence of the ducts and above the lower end of the common bile duct, where the cystic duct joins the common hepatic duct to become the common bile duct, you have a differential diagnosis of common hepatic duct tumor or Miritzi syndrome. Starting with the usual routine investigations, the liver function test is the one that is most important, and it will show elevated bilirubin and elevated alkaline phosphatase, which are the hallmarks of bile duct obstruction. You may get elevation of the AST and the ALT, which we call transaminitis colloquially, and usually these levels will be less than 3 to 4 times the upper limit of normal. Upper limit of normal is usually 50, so AST and ALT are usually below 200 in these patients. Anemia may occur. Remember, anemia is not a routine finding in these patients, and if you see anemia, think about periampullary tumors, which are periodically sloughing with upper GI hemorrhage along with bile duct obstruction. Doing a CA19-9, which is the only really reliable tumor marker, is a common part of the investigations. Remember that this is not a very reliable test. Elevations can be seen even in benign disease, but if it is very high, like in the thousands or more than 2,000 to 3,000, it's usually a reliable indicator of disseminated disease. Ultrasound scan is the next screening investigation, and we have talked about this. It is easy to detect dilatation of the intrahepatic bile ducts. You have to look for dilatation of the gallbladder, and its ability to pick up anything on the pancreas itself is limited. Diagnostic imaging usually involves a CT scan or an MRI scan. CT scan is presently the standard of care. It is important to remember that the CT scan should be specific for the pancreas or a pancreas protocol CT scan. This is only possible if, before ordering the CT scan, you have got a good clinical diagnosis, you have in your mind done a clinical pathology correlation or a CPC, and you're specifically looking for something in the pancreas. A screening abdominal CT scan will subject the patient to radiation and exposure to the dye and toxicity to the kidneys if you have to repeat this in order to really delineate what's going on in the pancreas. If you want to do just a screening investigation, perhaps MRI combined with MRCP may be the better option. However, it's important to remember that reading an MRI and MRCP is difficult, and you have to have an experienced radiologist to do this. ERCP is a common investigation nowadays, and many times patients are sent to ERCP after the screening ultrasound shows dilatation of the bile ducts. This may or may not be a good idea because in the presence of bile duct obstruction, ERCP can introduce infection above the level of obstruction. Usually ERCP will have to be combined with placement of a stent, and the patient will have to live with the stent until a definitive diagnosis is made. ERCP is often combined with endoscopic ultrasound, EUS. EUS again is an investigation that is not done routinely and has to have specially trained and certified endoscopists to do that. EUS and FNA, or fine needle aspiration of the head of the pancreas, is another diagnostic imaging tool but requires good correlation and cooperation between the endoscopist and the pathologist. Remember, failure to obtain histological diagnosis of carcinoma of the pancreas is not sufficient reason to hold up further treatment. A word here about inoperability versus unresectability. Very often we use these terms interchangeably, but they are strictly speaking not interchangeable. Inoperability means a patient in whom you cannot think of offering any attempt at a curative operation. These are patients in whom there's clear signs of dissemination of disease clinically. They will present with enlarged supraclavicular lymph nodes, malignant ascites, and on rectal examination, you may be able to palpate deposits of the tumor in the pelvic peritoneum, which present as a classical sign called the rectal shelf of Bloomer. Another reason why a patient may be inoperable is because he or she is just too frail. They may have too many comorbidities, cardiac, renal, pulmonary, which preclude an attempt at a curative operation. Remember that in somebody with jaundice, they usually have no appetite and they will lose weight and become very frail very quickly. And sometimes it is frailty that makes the patient inoperable. How do you assess frailty? There are several scoring systems. Perhaps the most reliable one is called the Liver Frailty Index, and the older one is called the Karnofsky score, which is less specific and less granular. Lastly, the psoas muscle is a sure indicator of frailty. You can evaluate the psoas muscle volume on the CT scan, which will tell you objectively whether the patient has clear evidence of frailty or not. In the context of disseminated disease, you may have to order a CT PET or a PET scan to prove this, in which case the patient becomes inoperable and only a candidate for either palliative treatment or no treatment. As opposed to inoperability, unresectability is diagnosed only on the basis of imaging or actual laparotomy or laparoscopy. Unresectability usually means that the tumor is too big. In my mind, I always think of 3 centimeters. Tumors less than 3 centimeters in size tend to be resectable. Tumors over that size can go on to becoming unresectable. Usually one looks for evidence of encasement of arteries. Above the head of the pancreas is a common hepatic artery and the celiac artery, which can get encased by tumor. This is a sure sign of unresectability. Below the head of the pancreas is the superior mesenteric artery, and this is directly in contact with the uncinate process of the pancreas. So tumors of the uncinate process encasing the superior mesenteric artery is another sign of unresectability. Notice that I didn't mention anything about the portal vein or the superior mesenteric vein. It is possible to bypass these veins, so the more experienced and aggressive a surgical unit is, they may be able to say that involvement of the portal vein is not a sign of unresectability. However, generally speaking, If the portal vein and superior mesenteric vein are encircled by tumor to more than 180 degrees, then this is also a sign of unresectability. All of these findings may have to be subsequently confirmed at surgery in a patient who is otherwise fit to undergo a laparotomy. JAMA 2021 gives you, in this reference, a valuable resource to see how tumor enlargement and encasement of the vessels is depicted in the form of a line diagram. I will also proceed to show you the same by doing a hand diagram. Tumors of the pancreas that arise in the head, body, or tail can encase the vessels running close to the pancreas. This is the celiac artery arising from the aorta. It gives off the splenic artery, which runs to the spleen, the common hepatic artery, which comes along the surface, upper surface of the pancreas, gives off the gastroduodenal, and continues as the hepatic artery proper to divide into the left and the right hepatic arteries. All of these vessels can get encased by tumor, and this is possible to visualize in a CT scan. This constitutes unresectability. It may have to be confirmed at surgery, either laparoscopy or laparotomy, but encasement of these vessels usually means this tumor, wherever it is in the head, body of the pancreas, is no longer resectable. To evaluate unresectability due to involvement of the superior mesenteric artery, which comes off below the pancreas, it is important to think of another view of this pancreas where the head of the pancreas has got the uncinate process. The uncinate process wraps around the superior mesenteric vein and comes in close contact with the superior mesenteric artery. Tumors in this area can grow and encase the superior mesenteric artery, and this also constitutes a sign of unresectability. Operating and resecting these tumors is the best chance of getting a good outcome, whether the outcome is curative or palliative. In this context, it is important to remember that most patients presenting with malignant obstruction of the lower end of the bile duct with jaundice undergo ERCP today with placement of a stent to drain the bile and reduce the bilirubin. What happens commonly is that in a busy gastroenterology clinic, that is all the treatment that is offered to these patients. So they continue to have poor appetite, sometimes infection supervenes, and they become more and more frail. So a good approach to these patients is the moment their biliary obstruction is relieved by stenting, start prehabilitation to make sure they get intensive nutrition and start doing the kind of exercises with the lungs and the limbs required to get them through surgery safely with early ambulation after surgery and a very short period of time on elective postoperative ventilation. Staging these tumors. I have here a reference from the Archives of Pathology and Laboratory Medicine, which I think is an excellent review of staging of biliary and pancreatic tumors. If you can find it, that's great. Otherwise, I have summarized it in this slide. Early stage tumors, or stage 1 and 2, are tumors where the primary in the pancreas is less than 4 centimeters in size. There are nodes which are maybe enlarged but do not test positive for malignancy or malignant deposits on pathology, and there are no metastases. Anything other than this is an advanced tumor where either the tumor itself is over 4 centimeters, or there are positive lymph nodes more than 4 in number, in which case it is N2. Previous stagings used to include peripancreatic infiltration of tumor or unresectability. These have been removed from the current staging. A word about neoadjuvant therapy. It appears logical that in a tumor with such a poor prognosis, giving chemotherapy or chemoradiation prior to resection will improve the prognosis and improve the chances of resection removing the entire tumor. This, unfortunately, doesn't happen in tumors in this location. The number one reason for that is that these patients are jaundiced. Nobody is going to give chemotherapy in the presence of bilirubin over 3 milligrams per cent. Also, in order to be able to start neoadjuvant chemotherapy, you have to have a reliable tissue diagnosis. Tissue diagnosis is often hard to achieve and to obtain in patients with tumors in this location. Two forms of chemotherapy are known, whether they are done as adjuvant or neoadjuvant. It can be either single drug, in which case the drug of choice is gemcitabine, or it can be multi-drug in a protocol which is known as the FOLFIRINOX protocol. Unfortunately, screening for pancreas cancer at this point is highly controversial and is not recommended. The reason is, to justify screening, you have to be able to provide the diagnosis very reliably when you do the screening test. The next thing is that you have to have a treatment that will have curative prospects. Neither of these can be reliably met with carcinoma of the pancreas, and therefore at this time, routine screening of the population is not advised. There is, however, a role for screening in certain select populations, and the list of patient populations in whom screening may today be justified is as follows. Early diagnosis is the only hope of success in the treatment of carcinoma of the pancreas. Remember, early diagnosis rests on high clinical index of suspicion. You may never get confirmatory pathology before you proceed with the actual treatment of these patients, even surgical resection. Surgical resection offers the only hope of cure and is still the best way to palliate this disease. We will learn more by collaborating. I look forward to your questions. Remember, a question which is of high value will attract a prize. And remember again that when you travel together, you travel far, and keep in touch.